everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for the Foundation, and today Dr. Tirisham Gyang is going to be discussing how to improve quality of life with MS. Dr. Gyang is an assistant clinical professor with the Ohio State University Wexner Medical Center, where she serves as a clinician and the program director for the Multiple Sclerosis Fellowship Program. She specializes in MS and related neuroimmunological disorders of the brain and spinal cord, and has a particular interest in experimental therapeutics, clinical trials, and medical education. She serves as the principal investigator in multiple clinical trials and clinical research projects. As the fellowship director for the MS Neuroimmunology program, she trains aspiring MS specialists in comprehensive clinical care and clinical research. In addition to her interest in MS and other demyelinating disorders, she has established multidisciplinary clinics in neurorheumatology and neurosarcoidosis. Dr. Gyang is passionate about empowering patients with personalized interdisciplinary clinical care, quality education, and clinical research. She completed her training in clinical MS and experimental therapeutics from the University of Rochester Medical Center as a scholar of the National MS Society. She is board certified as a neurologist and is an active member of multiple professional societies. We will address all questions and comments at the end of her presentation, but Dr. Gyang, thank you so much for being with us again, and I'll turn it over to you.
Thank you so much, Kimani, for that wonderful introduction. And I'm really excited to be back again. We were just talking about, it's been about a year since the last time, I did a presentation with MS Focus, and I'm really, I always look forward to my presentations with MS Focus. I will share my slides in a minute so that we can get started. All right, so I hope that you can see my slides. I'm sharing them right now. Okay, perfect, you can see them. So I titled this presentation, Overcoming MS. And I really love this title because, as of now, we don't have a cure for MS. Once we diagnose a person with MS, unfortunately, that's a diagnosis they carry for the rest of their lives. We don't have a medication or an intervention that will completely take MS away. And so, whenever I meet patients, we talk about how do we overcome MS, despite the fact that we can't cure MS? How do we live a life of high quality, despite the fact that we have this diagnosis that cannot go away? Hopefully, someday we will have that treatment that can completely cure MS, but we don't have that right now. And so how do we live in such a way that MS does not become a hindrance to our patients, our loved ones, achieving the best lives that they can? And so that's the reason for the title, Overcoming MS. We don't have cures, but how can we still overcome the disease and live that life that we all, wanted to live or set out to live in the beginning? These are my disclosures. I've served as a consultant for a few different companies that are listed up. All my clinical recommendations are based out of evidence, and none of these consultation activities have any conflict with what I'm presenting today. Okay, so just an introduction about multiple sclerosis. I know most of us listening know MS, have experienced MS, or have a loved one with MS. Now, this is just the background on what MS is. MS is an autoimmune disease. Autoimmune means that your immune system, one's immune system, rather than defending you against like bacteria, viruses, cancer cells, rather than doing that, it turns up on itself. It turns up on something that is part of who you are. So that's an autoimmune disease. It affects primarily the central nervous system. And to simplify this just means the brain, the spinal cord, and then we always talk about the optic nerves. These are the little cables that connect our eyes all the way to the brain. Those are the organs that are primarily affected by MS. The immune system mounts the attack against the fatty sheet that encapsulates our nerves. So there's an insulation. Our nerves are long cables called axons. These nerves have an insulation that covers them, a very fatty tissue called myelin. So the immune attack is targeted against myelin. The myelin is that fatty tissue that surrounds the cables, the nerves, the axons, and the immune system, for reasons we haven't clearly understood, target that part of the nerve and keep attacking that part of the nerve. If you think about disability in young adults, so, young adults, they're building their careers, building their lives, building their families. MS is the second leading cause of disability. Now, this is a very serious problem. The first leading cause of disability is trauma, and the second leading cause is MS. So this is a pretty significant problem, and it starts very young, right? Other conditions, for instance, like Parkinson's, may not start as early. MS starts very early, and this is a diagnosis of an individual will carry on, for the rest of their life. Affects about 1 million people in the US, based on the most recent data that we have from a study that was done. And people with MS present very differently. So one person with MS is going to present completely different from another. And sometimes I've even seen that in the same family, you have more than one person with MS, and they look completely different. One person maybe has some disability and the other person has a completely different set of disabilities. So MS is a very, we say, heterogeneous disease, meaning it presents very differently in different people. Now, whenever I talk about MS, people always ask, what causes MS? When I talk to a patient that they've been diagnosed with MS, it's like, okay, what went wrong? Did I do something? Is it a genetic condition? How can I fix this? I need to understand what happened. We don't have one cure for MS. We don't know exactly what goes wrong that triggers this autoimmune process. But, my mentor from fellowship always said it's kind of like a perfect storm. You have genetics. So MS is not an inheritable disease. It's not the way we think of inheritable diseases, like cystic fibrosis or sickle cell anemia. MS is not a genetic disease in that sense, but many genes have been implicated with the risk of MS. So you may be able to inherit a risk or a predisposition based on, your genetics. There's an immune dysfunction. We don't understand why that happens, but there's some kind of immune dysfunction that happens. And then lastly, there's multiple environmental risk factors that have been associated with MS. For instance, where you live, so your latitude, where you live, meaning how, for the most part, how close or how far you are from the equator actually determine the risk of MS in that specific location, where higher incidences, the further away you go from the equator, the higher the incidence of MS, or the higher the prevalence of MS. Adolescent obesity, viruses, there's a lot of data on EBV recently being a potential cause for MS. There's a lot of research on the gut microbiome. I talk to my patients a lot about vitamin D level, because low vitamin D levels have been associated with an incidence of MS. Smoking. So patients or people that smoke, smoking carries people that smoke have a higher risk, and certain dietary factors that have been identified. So we don't have one cause. We don't have like one principal thing that happens, but it's a bunch of different things. There are different types of MS. Whenever whenever I diagnose a patient, I always try to give them the education about, what type of MS they have. The different types of MS, including the relapsing types of MS and the progressive types of MS. Uh, Clinically isolated syndrome, this is the first attack of MS. Sometimes you haven't even quite met the diagnostic criteria yet, but you've had that first relapse. We can't call it MS, but from all indications, it looks most likely like the beginnings of MS. It's called clinically isolated syndrome. And at this point, we have the data that says we treat as MS because these patients are most likely to transition into what's called relapsing remitting MS. Relapsing remitting MS, these are the patients that have, or the individuals that have relapses followed by remission. So for instance, you may have a relapse with optic neuritis. You kind of have that vision loss that starts up all of a sudden, takes a few days, a few weeks and gets better. And then you wait around and then give it a few months, a few years, another attack happens. People keep having these attacks back and forth, gets better after the attack. And then, after some time, there's another relapse that happens. So that's relapsing remitting MS. Over time, some patients, instead of as relapsing remitting MS, transition to what's called secondary progressive MS. And this means that rather than having relapses and remission, in the background of that, there's a slow progression in disability. Just that slow progression that is permanent. It's not getting better like, you have a relapse and remission. It's just a slow progression in disability. There may be relapses that happen in the context of that slow progression, but overall, when you look over time, in 1 year, they're walking fine. The next year, they have to that person has to use a cane. A few years later, they're using a walker because they can't use the cane anymore. And give it a few more years, they're in a wheelchair, right? So it's that slow progression in disability. And then lastly, we have what's called primary progressive MS. These are patients that never have relapses. They just start off with slow progression and disability, and it just keeps progressing over time. A few patients, it's not common, may have relapses at some point, but most of the patients with primary progressive MS do not have relapses. At least it does not start with a relapse. For the first year or so to qualify for that diagnosis, it's 12 months of progressive disability. Generally, they don't have relapses in the beginning. So these are the different types of MS. A little bit about the epidemiology of MS. The relapsing remitting MS type is more common in women. So women to men is about 3 to 1. However, the primary progressive MS is about almost equal between men and women. So slightly more common in women at 1.2 to 1. So definitely not as different, definitely about the same compared to when you think of relapsing remitting MS. What's the average age of onset? About 30 years for relapsing remitting and 40 years for primary progressive MS. And then we talked about the genetic susceptibility. So if a close family member of yours has MS, for instance, your brother, your sister, your father, your mother, the risk of a first degree relative. So if you have somebody very close to you that has MS, you are more you have a slightly higher risk of having MS than someone that has no family member with MS. But in general, the likelihood is still pretty low. So the last set of data we have, if you have a direct family member with MS, first degree relative, it's a 2.5% risk that somebody with that relative is going to get MS. So it's still pretty low, but it's a lot higher than someone that has no family history of MS. The prevalence of MS in the US. So this is what is called a latitudinal gradient. And I think I talked about this slightly. As you move up north, the prevalence of MS increases. So the prevalence is lowest down here in the south at 272. As you go up to the Midwest, it becomes 350 or 353. In the West, it's about 272. When you go all the way to the Northeast, we're going up to 375 per 100,000. So we could clearly see that there's the prevalent changes or goes up as you move northward. And this has been seen not just in the US, but in other parts of the world. MS has been identified in all demographic groups, all racial groups. The highest prevalence is in white individuals of Northern European ancestry. So those are the groups that have the highest prevalence. However, we see that there's a growing incidence of MS in ethnic minority groups. So whether we're talking about Hispanics or Black individuals, there's an increasing rate of MS amongst these groups. And the most recent studies show us the highest incidence of MS. Incidence means newcomers, the new people being diagnosed with MS. The highest incidence in 2 studies that were done, the highest incidence was seen in Black women. And then when we look at minority populations in the US, they have a higher incidence of MS when compared to their home countries. There's a higher prevalence or incidence of MS here for people that live here than in their home countries. So, what I talk to my other doctors or my students, my residents, is that MS can happen in everyone. Gone are the days where we thought MS could only happen in specific, demographic groups. We always learned that MS happens in white individuals. MS can happen in everybody. How do we diagnose MS? Typically, people present with, at least the relapse and remitting MS, present with new neurologic symptoms that start all of a sudden. So it could be losing vision in one eye, weakness, let's say on one side of the body, or numbness, tingling in a specific part of the body, vertigo or dizziness, or difficulty walking all of a sudden where you feel like you're wobbling, you're falling, you're having trouble doing that. These could come as attacks, meaning it comes all of a sudden, you're doing fine, all of a sudden you wake up and you have these symptoms, or it progresses over a day or a couple of days. And in patients with primary progressive MS will have very slow progression in, for instance, walking difficulty. And that goes on for at least a year to meet that diagnostic criteria. So first of all, you have to have symptoms of MS. We can't diagnose MS if you have no symptoms at all. The second most important tool, when you have symptoms, the second most important tool in coming up with that diagnosis is the MRI scan. Typically like to get MRI of the brain, MRI of the spinal cord, and when it's appropriate, we get MRI of the optic nerves to look at those optic nerves to see if there's any active inflammation in the optic nerves. I have put a few pictures of MRI scans, and you can see the white spots within the brain. They usually appear in distinct locations. I wouldn't go through all the medical terminology, but we have these lesions, we call them lesions, in different parts of the brain. And to meet the diagnostic criteria, they have to be in specific parts of the brain. We look for the shapes of the lesions. Sometimes we see these spots in the spinal cord as well. And that just tells us there's an area of inflammation. At some point, there was inflammation in that part of the brain or that part of the spinal cord. We typically get the MRI scan with contrast. They inject the contrast in your vein. Sometimes it helps us to see if there's active inflammation. Now, there are additional tests that can be helpful. The spinal tap can be helpful. Not everybody gets a spinal tap, but some people, in some cases, it helps to confirm the diagnosis. Sometimes we get blood tests to rule out other conditions that we call mimic MS mimickers. They mimic MS. And there are other tests, evoke potentials that we could get to help to confirm the diagnosis. The 2 most important, I would say, 1, you have to have symptoms that are typical for MS, and then we have to see the scars or the lesions on the MRI scan. And so diagnostic tests, we talked about MRI scan. Sometimes a spinal tap is necessary. We don't always need one. Sometimes we do evoke potentials as the patient getting what's called the visual evoke potentials. And then sometimes we do blood work just to rule out other things. Sometimes we do blood work to make sure, could this be lupus? Could this be a different type of disorder? There are other types of disorders that may look like MS. One common one, or not, one that we typically talk about is NMO, or neuromyelitis optica, that could mimic MS, but it's not MS. We have another one called MOG antibody disorder that also may look like MS. So sometimes we need to get blood tests to rule out other things that could mimic MS. Okay, so now we're going to talk about management of MS. We just talked about how MS can present, potential causes of MS, who gets MS. Now, at the point where you have MS, what are the different things that we could do to help an individual with MS to have high quality of life? What are the tools that we could use to prevent disability? And I'm going to go over all of these, and I'm going to go over them in detail, and hopefully we have some time for questions at the end. So disease modifying therapy, I will talk about the different treatments that can help to reduce relapses or prevent the progression of MS. We want to treat symptoms of MS. So if there are symptoms of MS, we want to find the best treatment for these symptoms. Sometimes clinical research can be beneficial. We do a lot of research in MS, clinical research. Sometimes there may be new and innovative treatment options that can only be accessible to clinical research, and it may be appropriate for some people with MS. And then we'll talk about lifestyle. So we're thinking things like exercise, diet, sleep, managing stress, just how can the day-to-day things that we do help to improve the quality of life. And then lastly, I'll talk about community or social support. We live in context of a community with other people. It's always helpful to connect with other people to get social support, and connecting with other people to just help deal with whatever symptoms or disability comes with MS. Okay, so let's talk about treatments or disease modifying treatments. Whenever I talk to patients, I say, okay, this is kind of the big treatment that helps to modify the course of the disease over a long time. If you're thinking, a 20-year-old, a 30-year-old is diagnosed with MS today, and we think about, okay, what is your life going to look like when you're 30, 40, 50, 60, 70, 80? The role of the disease modifying therapy is to prevent long-term disability, is to prevent things from progressing over the course of the disease. So most of them work by preventing further inflammation from damaging the nerves, whether it's in the brain, the spinal cord, or the optic nerves. In the case of relapsing remitting MS, these medications prevent relapses. Now, if in the case of relapsing MS, if we allow relapses to just keep happening, that leads to accumulation of disability. So even if you're rebounding from relapses, over 10, 20, 30 years, at some point it catches up, right? And there's accumulation of disability. So if we prevent the relapses, we help to prevent the accumulation of disability. In the case of primary progressive MS, people don't have relapses. So the treatments are more targeted at slowing the progression of the disease. We don't have a lot of treatment options for primary progressive MS. There's a lot of studies going on right now to try to answer that question, but the idea is, can we slow the disability, the progression of the disability? So that is the role of disease modifying therapies. Now, there's different types of medications. I'm sure a lot of you have heard about them, have seen them. Some of them are infusions. So you would have to go to an infusion center and get the IV placed, and then you get the medication by an IV. Some of them are pills that you take by yourself. Some of them are shots that you're going to learn how to administer by yourself. And so there's different types of there's different treatments and different ways to get these treatments. This is a list of some of the disease modifying drugs. I'm sure a lot of people can recognize some of the names. The first set of treatments were called interferons and glatiramer acetate. Those came out in the 80s, these two groups. So medications like Rebif, Betaseron, Avonex, Plegridy, these are all injections that are given at different time intervals depending on which one. And then Copaxone, or another version that came out was Glatopa. That's another option. Came out in the 80s. At least Copaxone came out in the 80s. And these are first line treatments, or treatments that were the earliest treatments that were used. In terms of pills, we have a few different pill options. Teriflunomide, also known as Aubagio. And then we have a bunch of other pills, the fumarates like Tecfidera, Vumerity, and then there's a newer one that just came out. It's not as popular as the other two, but there's 3 different options for the fumarates. And then we have another class of drugs called the S1P modulator group. So drugs like Gilenya or Fingolimod, Mayzent or Siponimod, Ozanimod, Ponesimod. These are a whole class of medications. And then we get to the infusions. We have a group of drugs called the B-cell depleting therapies. Ocrelizumab is the most common within that group. And then we also have others like rituximab. There's a short version or injection version called Kesimpta or ofatumumab. And then there's a new one that just came out, Briumvi or oblituzumab. So most of them are infusions, but at least one of them is a shot, work by depleting or destroying the B cells. Another very important infusion is called natalizumab or Tysabri. This one is given once a month. These two groups, the B-cell depleting drugs and natalizumab, these are very effective medications to preventing relapses. And then we have a few others, alemtuzumab or Lemtrada, and then cladribine. These are treatments that are uniquely given, they're given at a specific time point, and then you stop giving them. They help to in some way reboot the immune profile to prevent relapses long term. So this is just a description of some of the medications that are available today, and this is progress. I still have patients today that were diagnosed in the 80s, and they tell me, I got diagnosed and my doctor just said, sorry, we have no medications for this condition. We'll try to treat you when you have a relapse, but we just hope it's the good kind of MS, because we really don't have a way to prevent you from having these relapses. So this to me looks like progress. We went from having nothing just, let's say 30 years ago in the 80s to having a host of different treatments. None of these are going to cure MS, but they will modify the course of the disease. And the best way that I describe this to patients is, let's say you're diagnosed with MS at 30. The trajectory of your disease would lead you to a point where you're disabled and you're in a wheelchair by, let's say, 45 or 50. Now, our question is, can we put you on one of these drugs to take us to a different outcome so that, you're diagnosed at 30 rather than being in a wheelchair by 45 or 50, you never get into a wheelchair because we control the disease very effectively. So that's what it means to modify the course of the disease. Okay, what treatment is right for a lot of times patients say, how do I pick a treatment? What's the right treatment for me? We don't have a way to determine in a specific individual what treatment is the right treatment for that individual. But you want to discuss with your doctor, and there's a few factors to consider. Number one is, how aggressive is the disease? Some patients have a very more aggressive form of the disease than others. If you have an aggressive form of the disease, you really don't want to start with the least effective drug. You probably want to start with the most effective drug. And then, do you have any other medical conditions? With some of these treatments, for instance, if you are a diabetic, it could be a problem doing some of the medications, with the fingolimod, for instance, you may be at higher risk for some of the complications if you have diabetes or if you have heart issues. If you had a recent heart attack or recent stroke, we cannot do some of the treatments in that category, in the Gilenya or fingolimod class of drugs. What other medications are you taking? With some treatments, we can combine them with certain medication. You may be on a medication for something else, and if it's not compatible with a specific MS medication, maybe we can't pick a specific medication. What are the other risks and benefits for the specific medication? Some patients may have, just based on lifestyle or other issues, a specific treatment option that may be better to another. And then, we always talk about this with our young women. Do you plan on becoming pregnant soon? If you have plans of building your family, or within the next couple of years, you want to have a baby, we want to know so that we decide what's the best treatment that we could at some point transition out of, so that we can effectively plan for pregnancy. And some of it is, what is your preference? Some people tell me, I don't like swallowing pills. If, I had to take a pill, I'm probably not going to be compliant and I'm not going to take it. If a patient tells me that, I try as much as I can to find an alternative, because there's no point in me giving you a medication if you're not going to take it. I have people that hate needles and they just never want to have a needle close to them. I try to coach them and show them what the needle looks like and how easy it could be if it's a patient that is really, really averse to needles and doesn't want to do needles. We try to accommodate and figure out what would be better. And then the other option is, how often are you willing to take medication? Some of these medications can be dosed in very, very wide intervals. Some of them, for instance, with ocrelizumab, it's dosed every 6 months, right? So maybe for somebody that has memory issues and has trouble remembering to take their pill every day, maybe doing a medication that doesn't have to be done every day, and you just have to remember twice a year to show up to an appointment, maybe that would be better for that patient than asking them to take a medication every day or even twice a day. So there is no formula, there is no method to say, patient A, this is the exact medication for you. It's a discussion with your doctor. We ask a lot of questions. We try to determine, based on who you are as a person and your lifestyle, your other conditions, what's the best treatment that would be appropriate for you. Ultimately, that medication should be able to control the disease. What are the goals of treatment? And I always address this with my patients. This is the main goal of the treatment. In relapsing remitting MS, the goal is no further relapses, meaning we don't want you to have more clinical relapses, and that we assess that by the MRI scans as well. Because even if you don't have relapses, if we see new lesions on your MRI scan, it means that there's still ongoing inflammation, and we probably may want to change that medication. For patients with progressive MS, the goal of treatment is to slow the progression of the disease. And sometimes this is a little bit more difficult to determine. If I start a medication, on a primary progressive MS patient, a year later, a couple of years later, it's sometimes hard to know, is this medication actually slowing the progression? Whereas in a relapsing remitting MS patient, I can just count, have you had any relapses and have you had any new lesions on your MRI scan? If the answer to that is no, it means the medication is working. The medications, the disease modifying treatments don't necessarily treat the symptoms, right? So sometimes patients tell me, well, I still feel fatigued, I still feel pain, I'm still weak, this medication isn't working. And I tell them, no, we treat the symptoms differently. If your disease is stable, we don't need to change that medication. We want a medication that you could tolerate, that has minimal side effects, a medication that is safe for you as a specific person, and a medication that you can take, you're able to take consistently. And I always tell patients, there's a medication you may be on for years. So if you take the medication and you feel bad right after taking the medication, you get nauseous or you just don't feel good, maybe that's not the best medication for you, because the goal is not to make your life miserable. The goal is to get something that you're able to tolerate and you could take long term. Okay, now we're shifting gears to talking about MS symptoms. As you could see, this is completely different from disease. I always separate these, there's one thing to control the disease itself, making sure you're not having relapses, completely different from managing your symptoms. What symptoms do MS patients have? This is a word cloud that just tells you what, a pool of MS patients reported in terms of symptoms. The bigger the word, the more times it appeared, or the more people reported that symptom. And you can easily tell what the most common symptom of MS is. It's fatigue. So a lot of patients with MS have fatigue. Pain, balance issues, cognitive issues, spasticity, depression, memory issues. And one person may not have all these symptoms. Everyone is different. People have different presentations. So these are just some of the symptoms, sensory symptoms like pain, numbness, tingling, motor symptoms like weakness, spasms, spasticity. We think of brain stem. So this is a specific part of your brain. Sometimes you can have vision loss or double vision, dizziness, balance issues, coordination issues. This is a specific part of your brain called the cerebellum. And then some of the MS symptoms have to do with just the impact of the lesions in the higher part of the brain. So cognitive function can be affected. Some patients have depression or anxiety, fatigue, sleep issues can be a problem. And then, bowel and bladder, there are patients that have constipation, trouble emptying the bladder, sexual dysfunction. So, and everyone could present, people with MS present very differently. Some people may have one set of symptoms and not the other. So just a list of some of those symptoms. If it's a sensory symptom, there could be pain, numbness, tingling. Sometimes it's called an electric shock-like sensation, or burning pain, shooting pain. There's different ways patients describe it. How about the motor symptoms? So patients can present with difficulty walking, weakness, balance issues, falls, fatigue in MS. We talked about it as being the most common symptom in MS, affecting almost, anywhere from 75 to 85% of patients with MS. Other symptoms, sleep dysfunction. Patients with MS have a higher incidence of sleep dysfunction than patients without MS. We talk of sleep apnea, narcolepsy, restless leg syndrome, cognitive issues. 40 to 70% of MS can have cognitive issues, whether it's memory, organization, processing speed. There's different ways it can present. Mood dysfunction, anxiety, depression, those can be more likely associated with MS. How do we approach symptoms? I'm not going to go through every symptom and say, this is how you treat pain. This is how, no. There's a lot of different ways to treat these symptoms. The approach I take and I always advocate for is first consider a non-pharmacological method. So Don't immediately go to a medication. I have this, let's do this medication. And I mean, sometimes patients end up with a very long list of medications. So we always first try to do a non-pharmacologic treatment, whether it's physical therapy, yoga, psychotherapy, mindfulness, sleep, getting better sleep, like sleep hygiene. Consider changing something in your lifestyle, sleeping well, eating well. Regular exercise is very, very helpful. It helps with maintaining a lot of the function that you have. It helps with managing fatigue, depression. So there's a lot of different things we could do before we jump into doing the medication. We only do medication if it's necessary. We want to avoid polypharmacy. Just means using too many medications at the same time, because sometimes they counteract with each other. Sometimes they don't play well together. So we only get to that part of the treatment if we actually really need a medication, and sometimes we do. But consider other things before treat a medication. We want to avoid addictive medications, and I always tell my patients, MS management is a marathon, not a sprint. So if you start an addictive medication, you're probably going to need it, for many decades, and you probably are going to get issues with taking that medication over a long time. These are some examples of some of the non-pharmacologic treatments like physical therapy, stretching, exercising, using devices that can support your limbs if it's necessary. Some people really benefit from things like acupuncture, massage therapy, that's a TENS unit. So these are very, very effective strategies for a lot of symptoms. Exercise is extremely beneficial. You want to get a physical therapist or trainer that maybe understands the disease a little bit, and they could guide you in exercise. It has a lot of benefits that I have listed. I don't think we have the time to go through each of them, but I always try to get my patients to do some kind of exercise. It may just be walk. Start walking for 10 minutes and then build up on it. Aquatherapy, aerobics, weightlifting, or strength exercises. There's a lot of different things you could do. I don't think we have time to go through this, but these are some medications that can be used, like for nerve pain. Gabapentin is a common one. For depression, for depression or also for pain, there are many medications that can be used. For spasticity, we talk of baclofen, tizanidine, or Flexeril. If it's more musculoskeletal pain, sometimes we do like ibuprofen or naproxen. We try to avoid opiates because, as I said, if it has there's a potential for dependence. It's most likely going to happen because MS pain is chronic pain. In the case of a relapse, we usually would do steroids to reduce the duration of the symptoms. Sometimes we go for surgical methods like injections or nerve blocks, or, for trigeminal neuralgia, sometimes we do certain procedures to help to prevent the pain. Some people get what's called a baclofen pump, that delivers the baclofen right into the spinal fluid where it's needed. Some people benefit from Botox injections to release some contractures in specific body parts. There's different devices that can help with weakness, like a brace, that's a foot up, it's called an AFO, ankle foot orthosis. That's a foot stimulator or hip flexion assist device for people that have weakness, different degrees of weakness. For walking difficulties, sometimes you may need a cane, a walker, or, ultimately some people are going to need to go in a scooter or in a wheelchair, a motorized wheelchair. Ampyra or dalfampridine can be used to help with walking or movement in patients with MS, but it can potentially lower the seizure threshold. So we have to be very aware of that. And then people with kidney issues, it tends to accumulate in the system. So we try to monitor for that all the time. There are a host of different assistive devices that can be used. there's, all sorts of Alexa and all sorts of apps that can be used, or write-in devices, or, just different tools to help people that have maybe coordination issues or other issues that make functioning more difficult. This is like a tool grabber that helps you to grab objects, say you have trouble doing that. And then different types of utensils, maybe in a patient with tremors, there are certain utensils that can help mitigate for that. Diet, I'm not going to spend a lot of time on this. We don't have a lot of time, but there's no specific diet for MS. People always ask, okay, which diet should I go on? Or they give me a list of diets like the paleo diet, the keto diet, all sorts of variations. We don't have a specific diet for MS. And if we just look in terms of medical evidence for diets, the Mediterranean diet has evidence in reducing cardiovascular disease and dementia risk. And so that is, for the most part, what we advocate to a lot of our patients. The simple, bringing it bottom down, I tell my patients, eat a lot of vegetables, fruit, if you're not diabetic, and blood sugar issue is not a problem, but vegetables, I think, are always a go. Healthy fat like avocados, nuts, olive oil, fish has a lot of healthy fat. Try to stick with the whole natural foods. So avoid the processed stuff that has been over refined. Improve your water intake, and then fish, rich in omega-3 fatty acids. What to reduce? Highly processed foods, refined grains and sugar or sugary products, trans fats, processed meats, or refined oils. Sleep, extremely important. You want to aim at getting very good sleep. Aim for 7 to 8 hours. Sometimes we have to do different things to help with that. If you're waking up every few hours to go to the bathroom, maybe you need to see a urologist to figure out how to keep your bladder from not overacting, where you have to go to the bathroom that often. Sometimes I send my patients for a sleep study because they may have sleep apnea, and that's keeping them from getting a good night of rest. If it's anxiety or depression that's causing you not to sleep, maybe getting into some kind of therapy may be helpful. And then you want to limit napping too often during the day, because that could affect getting good sleep at night. There are a few different prescription medications that may be helpful for sleep, but as we said, we don't jump to the medications first. We try all other non-pharmacologic methods before we go into using medications. With cognitive function, we talked about MS causing memory issues with, processing or cognition. Sometimes people do what's called cognitive rehab, can be helpful. Sometimes anxiety or depression can actually cause cognitive issues. So we want to make sure that is well taken care of. If there's anxiety, if there's depression, you want to make sure that that's well taken care of. You want to engage with the community and get a very good support system. And then if you don't sleep well, your cognitive function may be affected. Regular exercise helps with improving cognitive function. So we really want to figure out what exactly is going on, and how do we best account for the cognitive and mood dysfunction that's going on. And then last but not the least, I think we have one other point after this, is that you want to get into a very good social support system, whether it's in a group, like a group support system, a support group. The National MS Society has a lot of opportunities. Something like this, we're doing with MS Focus. This is kind of like a group session where we're just talking about MS. This is a community. We were forming a community and just helping ourselves. Some of my patients get into all sorts of, like a knitting group, a fitness group. Do what you love, what interests you, a book club. Just get in touch with community, find people that you can live life with and can help you improve your quality of life. And then there are lastly, I think I just want to make sure I leave some minutes for questions. Research. Sometimes research can be something that is very beneficial. There's different types of research, you know, preclinical, clinical trials, investigator initiated studies or registries. I just have a brief a few slides on, clinical trials that are done to investigate an intervention, say a medication, right? We're trying to test if this medication is going to help patients with MS. Sometimes there's a trial that's done to help to determine if that medication is helpful. There's a long process that goes with, getting that medication to a point where it's approved. But at some point, there are people with MS that had to say, I will go into this study. I'll take the chance. I may be on a real drug or a control or placebo, but I'm willing to take that chance. So clinical trials are one type of research. The other type of research is called like a registry. So we get a registry, like a study that looks at big numbers of people with MS, and we monitor them over time, and we get a lot of data to just help us understand the disease better. An example of this is the COVIMS, which was a registry for MS patients with COVID-19. There's also another one called the NACROMS, which is another registry looking at big cohorts of people with MS. Gives us a lot of information to help understand the disease better. I'm gonna skip this slide because I initially put it, as just talking to our patients about center. Well, I could talk about an MS center, right? So if you want to find a place that can manage all your needs, right? So you want to make sure there's a place where you could see a physical therapist, you could see a speech therapist if you need one, if you need another doctor that's not a neurologist, like a urologist or psychiatrist, you're able to see one. A lot of patients need to see an ophthalmologist. So this was just the example, just to say what are the different specialties that may be necessary if you have MS, and find a team that is able to help you, connect you with the right people to be able to manage these symptoms. All right, that is the end of the presentation. I just wanted to leave some time so that we could address questions. So thank you very much for listening. I'm not sure, I'll put it back to Kimani to direct us on how to address the questions.
All right, thank you, first of all, Dr. Gyang, again, for the insightful information. And we do have some questions, but before we do get into that, I just wanted to let everybody know who's watching us on Zoom or Facebook how they can interact with you during this time. So if you guys are watching from Zoom and you have questions for Dr. Gyang, you can either type them into the Q&A or the chat box below. You also have the option to raise your hand to speak directly to Dr. Gyang and ask your question. If you're watching from Facebook, you can just type your question into the comment section, and then they'll be directed to us and we can address them here. I see some questions in the Q&A, so I'll start there. An anonymous attendee, this is potentially a typo, Dr. Gyang, so if this does not make any sense, please forgive me and the person who wrote it. So I'm assuming it means, can medicine help when you have those symptoms from a DMT, but it says candle medicine, and I don't know what that is.
Yes, so, okay, yeah, I think, can medicine help when you have those symptoms from a DMT? I'm going to take a stab to guess that you mean you're having side effects from DMT. So maybe you're taking a DMT and you have a side effect from that DMT. Sometimes, yes, we do medications. For instance, with Tecfidera or medications in that category, if you have GI side effects, meaning you have some gastrointestinal side effects, sometimes medications can help. With the interferons, I see the next question is about flu-like symptoms. If you get a flu-like symptom from a DMT, so the interferon injections typically will cause flu-like symptoms. And, I still have a few patients on those treatments. Sometimes I tell them, half an hour before you take the medication, take Motrin, Tylenol, take, and one of the NSAIDs, so the non-steroidal anti-inflammatory. And in some people, it's able to help. Some people take that medication first and then take the interferon. So yes, there are treatments where there are cases where DMT could give you symptoms or side effects, but you're able to take a medication to help with it. And if it works and you're able to deal with that, then you go for it. So I would say, yes, talk with your doctor and see if there is a medication that can help. And I think that goes the same as Jana Pine's question, flu-like symptoms. If you have flu-like symptoms, if you have flu-like symptoms, can flu medication help? No, because flu medication is specifically for the flu. If it's coming specifically from a DMT, then depending on what that DMT is, there may be medications that can help. If it's an interferon, sometimes Tylenol, Motrin, the non-steroidal anti-inflammatories can help. But the flu medication, unfortunately, is not going to help with flu-like symptoms if you do not have the flu.
Ree Coleman wants to know how TENS therapy helps.
That's a very good question. I'm not a physical therapist, so I probably will not answer this the best way, but the TENS unit it's like you get very mild stimulation, like an electric stimulation from a TENS unit. I work with physical therapists, and some of them do, use recommend TENS unit to patients. Unfortunately, I cannot tell you exactly how beneficial it is. That would be something a physical therapist maybe would do better justice on. I don't want to say something that maybe isn't completely correct.
Teresa wants to know if you would recommend high-dose IV steroids for a patient with primary progressive MS.
This is a tricky one. So high-dose steroids typically are used when a patient has a relapse. So typically when there is a relapse, we give high-dose steroids to shorten the duration of symptoms. In the past, especially before Ocrevus came out, sometimes we would do pulse steroid dosing, and that would be, we do a high dose of steroids once a month to see if it could sustain the progression and disability. I haven't seen that done as often now because, Ocrevus has been out. High dose steroids don't have a very specific role with primary progressive MS, but, based on my experience, anecdotally, I've had patients that have done the pulse steroid dosing, where you just get that high dose once a month for an extended amount of time, maybe 6 months, and it to some degree helps you manage the symptoms or just helps to slow the progression to some degree. It's not FDA approved for that. I don't know that there are studies that have looked specifically at that, but there's somewhat of a role that can be discussed with your doctor. It's not a standard therapy. High-dose steroids are not a standard therapy for primary progressive MS, though.
Yeah. Teresa wants to know what your opinion is about Kesimpta being effective for primary progressive MS.
Good question. And I've, had a few of my patients where for some reason we can't do Ocrevus. So FDA approval, Ocrevus is the only drug that is approved for primary progressive MS. So if you're looking for the drug for primary progressive MS, Ocrevus, that's the drug. Now, we know Kesimpta or ofatumumab has the same mechanism of action the same mechanism of action as ocrelizumab. Kesimpta was not studied in primary progressive MS, was studied in the relapsing forms of MS, but we know it has the same mechanism, meaning it's going to do the same thing in your body that Ocrevus would do. So just thinking about it in that way, it's probably going to have some degree of effectiveness since it works the same way as Ocrevus, which is approved but Kesimpta is not officially FDA approved for primary progressive MS. And so it's kind of a yes and no, right? It's not officially approved. It works exactly the same as Ocrevus, which is effective to some degree. And Ocrevus is not effective in all patients with primary progressive MS. In some patients, it is effective. And so it potentially could be effective, but it's not FDA approved for that purpose.
We have another question in Q&A, and someone wants to know if you can recommend an MSPT or OT.
Okay, I don't know where you live, or I know there's a webinar going all over the country. I only know of the physical therapists that we have here at Ohio State University. So I'm not sure exactly if you live anywhere close to Columbus, we're happy to have you, but find an MS center wherever you live. The closest MS center, most of the time, they are able to connect you with the right physical therapist, the right occupational therapist. Sometimes you may need, a urologist, whatever services you need. If you find a comprehensive MS center, the MS Society typically list, the centers, the comprehensive centers that are affiliated with them. If you have one close by, I would say that you should ask them or try to figure out from them if they can refer you to a physical therapist or occupational therapist. Okay, I think you're muted. I can't hear you.
I'm so sorry about that.
Yeah.
We have a question from Facebook. Jess is asking about Anne Baroque's diet. She says that it helped her manage symptoms until she got pregnant. And if you have any thoughts on the Candida diet for MS.
I am not aware of that diet. And Baroque's Candida diet. That's something I have to look up. I mean, that's something I just learned today. I have not heard of it. And for that reason, I can't really say anything about it because I really, this is the first time I'm hearing about it, and I will look it up. In general, with diets, I tell patients, we don't have any diet that has been specifically studied to show strong effectiveness in MS. There are diets that have been studied, but we don't have any big diets that have said if you take this diet, this is a specific outcome. So, I always advocate that my patients take a balanced diet. Don't skip major food groups. Don't skip carbohydrates entirely. Eat healthy carbohydrates, avoid sugars, but don't completely stop taking carbs or stop taking a big food group. Find the healthy alternatives from that food group that you could take. So I don't know about the Candida diet. So unfortunately, I can't say anything about that, but I would say to do a balanced diet, tons of vegetables. You can add fruit if you're not diabetic and you're not concerned about blood sugar spikes, and healthy fat. Limit all the sugars and the processed stuff.
Veronica asks, if your electrolytes are off, does that affect your MS? And what can you do to improve MS treatment? MS treatment causes disturbance that can cause your electrolytes to be off.
Yeah, so if anyone's electrolytes are off, that is not good. If you don't have enough sodium, for instance, you could have seizures. If you have too much calcium, if your electrolytes are off for any reason, medically, you're not going to feel well. You may have conditions with that. Work with your doctor, both your neurologist and your primary doctor, to identify if there's any electrolyte imbalance that needs to be corrected, and then go on the appropriate treatment for that. But yes, electrolytes being off can make MS symptoms feel worse. And even if you don't have MS, it's when your electrolytes are off, it could make it worse. So you definitely want to get that addressed.
I have another question here from Tawana. I don't know if it's Tawana or Tawana. I'm sorry if I'm butchering your name, but she wants to know what your thoughts are on, is it Ribuxin infusion?
Okay, I'm gonna assume you mean rituximab. I'm not, I think that was misspelled. Maybe I'm gonna assume it's rituximab because I don't know exactly if I spell it that way. I don't know what that is, but rituximab, we used it a lot before ocrelizumab came out or was approved. Rituximab works very similar to ocrelizumab. If I have a patient and I'm not able to get ocrelizumab for any reason, sometimes I use rituximab. Does exactly the same thing as ocrelizumab would do.
And Steve from Facebook asks, how aggressive is Ocrevus as a treatment?
How aggressive is Ocrevus as a treatment? Well, and I'm not sure what you mean by aggressive. Or do you mean how effective it is as a treatment? For relapsing remitting MS or the relapsing forms of MS, it is very effective in preventing relapses. The studies, the clinical trials showed very, very good evidence that it helped to suppress relapses or new MRI lesions. So it's very effective. A lot of my patients on Ocrevus don't have further relapses once they've been on it for long enough. For primary progressive MS, it's a slightly different story. Not everybody in the clinical trial responded to Ocrevus. Even when we look at the people that responded, the response sometimes wasn't a very robust response. And people that were younger, in their 40s and 50s, were more likely to respond. I think, if I'm not mistaken, men responded a little bit better than women in the study. And people that had oligoclonal bands in their spinal fluid, meaning they had inflammation in the spinal fluid, were more likely to respond, at least in the preliminary studies with rituximab. So with primary progressive MS, the story is not as clean, because with the trial, there's just a lot of things that, we could say some specific groups didn't respond as well as others. So, it's not as helpful with the primary progressive. It's the only treatment we have, but unfortunately, we don't see like a very robust response with ocrelizumab. With the relapsing forms, it's very effective.
We do have a question, or a comment rather, from Robert. He says that he was on Ocrevus for 4 years, and on his 8th infusion, he had a heart rate over 150 and had to stay in the hospital and stop Ocrevus. He says he's on Kesimpta now, but he hasn't seen any progress on this as he had when he was on Ocrevus.
Yeah, I think that would be something to talk with your neurologist about, and maybe look for an MS specialist depending on who you're seeing. One question I would ask is they could check your B cells. When we give you Ocrevus or Kesimpta, we could check the B cells, because the purpose of these medications are to destroy the B cells. There's a simple test that can be done to figure out how many B cells do you have left. And so if for any reason you're on Kesimpta and it's not suppressing the B cells as effectively as Ocrevus, then, it may mean that it may not be as effective. Your doctor can maybe do some more investigation to try to figure out if there's a specific reason Kesimpta is not working as effectively. Somebody mentioned rituximab. It's another medication. It's not FDA approved for MS, but it's another medication that works just as Ocrevus. So, maybe a matter of talking with your primary doc or your neurologist about what if we do a different infusion, like rituximab. It's off label. We're using it off label for MS, but it's very similar to ocrelizumab. But I don't have all the details, so I can't really tell you exactly what the answer is. I think it's a discussion with your doctor, or you could maybe seek for a second opinion at an MS center to talk to an MS specialist.
Dr. Gyang, do you know why the prevalence in MS is higher in women?
That's a good question. Most autoimmune diseases, whether you're looking at lupus, rheumatoid arthritis, with MS, we think of other conditions similar to MS like NMO, most autoimmune conditions are more prevalent in women. Now, there's a lot of research that has gone into this. Could this be due to our hormones? Could this be due to the fact that women have to carry pregnancies? And so our immune system is built a little differently to be able to accommodate, tissue that isn't ours in our system. We don't have a specific reason, but in general, most autoimmune conditions are more prevalent in women than in men. Very good question.
Yeah, I was just wondering if that was something we knew for sure or not. But
Yeah.
you also mentioned sleep hygiene and the importance of figuring out why one was having sleep issues. And you mentioned therapy to help, but what kind of therapy were you referring to?
I mean, sometimes I send my patients to doctors that could just figure out what is going on and give you different techniques of how to wind down at the end of the day so that your body knows that this is time to rest. And so the routine may be different in different people. For some people, it may be maybe take maybe a few minutes for meditation at the end of the day. Some people take a bath, drink, something that helps them to just feel calm, like, certain types of teas. So there are people that, will actually coach you on sleep hygiene. A lot of they talk about avoiding use of electronics, when it's time for bed, shutting down the noise, shutting down the TV, just using your bedroom for sleep as opposed to other activities. So, there are specialists that could help with that. And if there is anxiety, if the problem is anxiety, like people go to bed and they just feel anxious. Your mind is just racing. You're thinking of so many different things, and you need some kind of psychotherapy to help you deal with that anxiety.
I also kind of feel like it's a good segue into the fact that the foundation is going to be publishing their first magazine issue on sleep and how to improve it in MS. And um, that will be the autumn issue for 2023. So be on the lookout for that in the coming months. I see that we have two more questions, one from Facebook and one here in Zoom. Facebook question is from Megan. She asks, are there any HCG trials? When I was pregnant, I felt amazing and symptom-free.
Yeah, that's a good comment. I'm not aware of any HCG trials going on now or that have gone on before for MS. So yeah, I'm not, and maybe I haven't looked hard enough, or maybe there is something going on somewhere that I'm not aware of. I'm not aware of any trials. I could say, I can say that, so what happens in pregnancy, in patients with MS? For the most part, in the later part of pregnancy, the risk of relapse goes down. So less likely to have relapses in the second and the third trimester of pregnancy. However, that risk picks up right after delivery. So, I've had patients that had a very bad relapse shortly after having a baby. So, with a lot of my patients, we have to plan way in advance, and we have to be aware of, what treatments are we going to be on that allows us to maintain the degree of relapse freedom that you have even while you're pregnant. A lot of the medications we do not use when you're pregnant, but some people do Copaxone, in pregnancy, but all the others are not medications that we use. And depending on how severe your disease is, there are certain treatments that maybe can be explored during pregnancy. Sometimes we do something like Ocrevus that's dosed 6 months apart so that you don't miss a lot, while you're pregnant, and you just don't get an infusion, but you still have the effect of the medication. But I'm not aware of a HCG trial, so I can't comment on that.
We have a question from Teresa again in Q&A. She says, is the neurofilament light chain blood test effective in diagnosing MS?
That is a good question. So there's been studies that have looked at this biomarker called the neurofilament light chain, We've looked at it both in the blood and in the spinal fluid, and it has been seen that when you have a relapse, an acute event, the levels go up. However, it's not specific. It's not a specific test for MS. So we can't reliably use it to diagnose MS because, it could go up for many other reasons. I've heard that it go in ALS patients, the neurofilament light chain goes up as well. And so it's not a very clean biomarker that we could use for MS, and it's not very reliable either. So at this point, it's more research-based and experimental. Some people are able to get it for clinical use, but it's not something that has been built into the diagnostic testing for MS, and we do not routinely get neurofilament light chains on a patient suspected with MS, because if you have the symptoms of MS, you have the MRI findings of MS, you meet that diagnostic criteria, it really doesn't matter whether your neurofilament light chains are elevated or not. You have that diagnosis. The neurofilament light chain is not specific or sensitive enough to diagnose MS in everybody.
Looks like we have some more questions coming in, Dr. Gyang. I know it is after 5. How much more time do you have?
I can keep going.
Okay, I was just making sure because I just realized that we were 12 after 5.
I'm fine with going on if, people want to hang around.
Okay, this looks to be an incomplete question from Jim. I'm assuming he's asking what drug interactions and reactions does one look for, but he doesn't really provide any detail. So
I can clarify that if you'll allow me. Jim had asked earlier, but the question wasn't clear. He said he was diagnosed in 2004 with RRMS, and he's taking spasticity medication and a long-running dose of Copaxone. So he was asking specifically about whether there are any interactions that he needs to look out for.
Okay, so he's taking antispastic
Copaxone and
tizanidine. Okay, yeah, it's difficult for me to comment on your medical management because I don't have the full story. So I think this is a good question for your doctor, and you could find an MS specialized doctor. I have a lot of patients that take both tizanidine, Copaxone, and baclofen, together. But I don't know your full history. I can't give medical recommendations based on just a few sentences. I have to sit with you, hear the full story, examine you, figure out what other conditions you have, and things like that. So unfortunately, I can't tell you specifically, but I think it's a good question for your doctor.
an anonymous attendee wants to know why aren't people who are diagnosed with MS automatically tested for their cognition?
Very good question. I think it depends on the doctor. I have a very low threshold for getting cognitive assessment. If I have a patient that's diagnosed and there is any kind of symptom that has to do with cognition, I get it. The thing with neuropsychological testing is, sometimes it's very difficult to get. A lot of times they have a very long wait list. One of the institutions I was at before, you could wait a whole year to get neuropsychological testing. And if a patient comes in, and they're not having any problems, sometimes it's helpful to just get a baseline of where that patient is. More often, people are more apt to get it when a patient reports some kind of difficulty with cognitive function. But I think it's provider specific. Some people are more apt to get it early. Some people are more apt to get it when you have symptoms. There is no official consensus. It's not a routine. It's not a test that can help you diagnose MS. But if you have an established diagnosis of MS and there are cognitive difficulties, sometimes it's helpful to get a better understanding to figure out, could this be something that is anxiety related? or depression related? Or could this be the MS itself, the degree of lesions that you have in your brain that are affecting your cognitive function? So it's a tool, just like an MRI. It gives us a picture of where you are in terms of your cognitive function. And it's provider specific. If you have cognitive concerns and you feel like that would be something that would be helpful in your management, it's definitely something you could talk about with your neurologist.
And I have another question in the Q&A. Someone wants to know how long it takes for meds to start working. They said first they were on Rituxan for 2 years, but then they had a relapse in June and they started on Tysabri. But as of, I'm assuming last month, they say they're still not feeling like themselves. So.
Yeah, and I mean, again, it's very difficult to give you medical recommendations based on just hearing a few details. A lot of medication, for instance, with rituximab or ocrelizumab, these medications become effective pretty quickly. Same with Tysabri or natalizumab. Sometimes it may take, a few months, in the case of rituximab or Ocrevus, but it's hard for me to tell you exactly what's going on without just having a medical, like a clinical visit and going through the whole story. What I would say is, talk with your neurologist. Sometimes it's helpful to get a second opinion, or to see if you're not seeing an MS specialist, maybe ask to see a person that specifically is a specialist for MS. But I always avoid giving medical recommendations just based on hearing a few lines.
Yeah, and I do want to encourage anyone who is attending through Zoom that we have had a bulk of our questions put in either the chat or Q&A. I know it's easier sort of to type them out. Some people may not want to raise their hand, but to kind of give more insight into your situation, that may help Dr. Gyang answer your question a little bit. So don't be shy. Your hostess here is an introvert. So if I can do this regularly, you can raise your hand and ask a question directly if you're comfortable. But we have another question from Jess from Facebook. She wants to know if she could request to get the Ocrevus infusion 5 times a year.
5 times a year. Okay, so the way that it is prescribed, it is given every 6 months. So basically the first cycle, when you're just starting, you get half infusion, and then 2 weeks later you get the other half. After that, you have to wait 6 months to get the next infusion, and then it's every 6 months you're getting 1 infusion. It's not medically approved. I mean, as long as your B cells are suppressed, I don't see a reason why you should get it more often. And the other thing is, there's no insurance company that's going to allow you to get it 5 times a year, because it's a very expensive medication. And, from that cost standpoint, they're just not going to approve for you to get it. The way that it was not studied given that often, it was studied given every 6 months. And so generally we tend to prescribe medications for the way that they were intended to be used in the clinical trials. For my patients, if we feel ocrelizumab isn't working, I would check the B cells. If you still have a lot of B cells, then okay, I think possibly there's something going on and it's not working. But if your B cells are completely suppressed and are 0, just giving you more ocrelizumab infusions, I don't think will change anything that much, because it has kind of done exactly what we wanted to do. And so again, it would be a discussion with your doctor. I'm not aware that, you can dose it 5 times a year. It's typically dosed twice a year, which is every 6 months after that initial dose of half doses 2 weeks apart.
Okay, I did see Jim's hand go up, but then it went right back down. So Jim, I don't know if that was an accident, but try to raise your hand again and keep it up until we call on you. Yeah, he keeps disappearing. I don't know why. Keep trying, Jim. In the Q&A, an anonymous attendee wants to know if IVIG or plasma exchange is effective for MS.
Very good question. I'll start with the plasma exchange. The plasma exchange can be used in the setting where you have a steroid refractory relapse, meaning you've had a relapse, we've given you a course of steroids, you're not responding. You have a very, very bad relapse where it's a lot of inflammation and one or two courses of steroids were not effective. The algorithm is that we can do IVIG in that setting, but there's no role for IVIG as a maintenance treatment for MS. I know some of the neuromuscular doctors, like for myasthenia, will have a patient getting maintenance IVIG, like once a week you get a session, or depending on what it is. We don't do that for MS. There's no evidence that that is going to help. So that is the only role for plasma exchange is in the setting of a very severe relapse or a relapse that has not responded to steroids. IVIG, not a lot of data. Similarly, in terms of the relapses that have not responded to steroids, there are some anecdotal studies that have looked at the use of IVIG. The data is all over the place. Some studies showed positive outcomes. Some studies did not show a very significant response. So the story about IVIG in terms of a relapse, a very bad relapse that hasn't responded to steroids, it's more on the fence. It's not on the algorithm of what to do. I think plasma exchange is more likely to help, at least from the data that we have, than IVIG. Similarly, we typically don't use IVIG for maintenance therapy, meaning just taking it long-term to prevent relapses. Not a lot of data to support that.
Jim, are you there?
I'm here. Can you hear me?
Yes.
We can hear you.
And see my geese? All right. First off, your presence and presentation is wonderful. And I went back and looked at what I typed, and yes, there was a typo. Copaxone should have read baclofen. I've got restless leg syndrome spasticity, and I see Ben Thrower, Shepherd Center in Atlanta. So I have a good neurologist, have had for 20 years.
Excellent.
But now the baclofen and tizanidine, just if I was wanting a little bit more insight, I know you can't do because you don't see me as a patient. I'm not asking that, but what would be a thoughts on interaction between the two to look if getting too sedated or when to take in the morning, when to take in the evening, when you're doing two of the spasticity relief medications.
Thank you for clarifying that. And that's a very important and relevant question. I have a lot of patients on both medications. I'm not aware of any specific interactions that prohibit you from being on both of them. What are the common side effects from these medications? You already mentioned one, sedation. So they tend to make you a little bit sleepy. Baclofen can make you weaker. I mean, baclofen more than tizanidine. So let's say there's weakness in a leg that's spastic. Sometimes patients feel a little weaker on that leg with the baclofen. But for patients that have really bad spasticity, I think it's a good thing to combine them because there could be some synergistic effects of taking both of them.
That's where I'm looking at is the synergy between when to take, because Doc Thrower and me, I've been seeing him long enough that we've referred to it as my soup. So different stuff I have in my arsenal to, when I'm having this symptom, I can take this. When I have that, I can take this. So those things are available. It's just trying to learn, is Copaxone or baclofen, which one is better for spasticity and versus restless legs? Because I'm finding that tizanidine is helping me get better sleep, but having sleep apnea, my whole list of symptoms are long. We could talk for a while, including white pizza in Rochester and working for a company that was outside of Cincinnati, but that was the 80s.
Yeah, I mean, in terms of when to take which one, there is no rule or set. I mean, with my patients, we just play around with it.
Point of interest, I've only been on tizanidine for not even a 30-day supply yet.
Okay.
So I'm trying to learn what the medicine, how it affects my body. So I guess I was kind of looking for insight on, because I'm very stable. I've typed Copaxone for that was the first 10 years. I've been 10 years. I hit 117 of Tisabri last Wednesday. So that was
Okay.
after a bad relapse 10 years ago, after I came off Copaxone.
Okay. Yeah, I mean, I would say, I mean, with my patients, there's no set way to combine these drugs. In some patients, they feel better taking one. Some patients combine and take both of them at the same time. Some patients stagger, meaning they'll take tizanidine first, and then a few hours later will take baclofen, and they take it in different time intervals. But there's no set way to do it in everyone.
No, if I was to do it the way it's prescribed, I would either be Jello or,
Yeah,
but
exactly. And so
you got to learn to juggle. You got to
Yeah.
know that MS is a never-ending. Every person. The one thing about MS, when I tell new people, because I've been part of a couple of different groups, that everybody's body shorts out differently.
Yep.
So yeah, we have common end run stuff, but how we got there could be totally different.
That is correct. So
and just trying to juggle my suit and what do I have in my arsenal to help this symptom. MS stands for moving symptoms.
I've never heard that one, but
It
that's
fits.
a good way to describe it. So yes, I would say, keep working with your doctor. It sounds like you have a very good doctor. Keep working with them, and there's no set way to do it. People respond differently. Some people are able to take it one way, and then in some people it may be too sedating. So it's a matter of juggling to see.
I was also thinking of being diagnosed forever now, not forever, but feels like it, to help new people coming along to be able to have a topic or a question. So
yeah, that's great. Thank you for talking on.
Would you be willing, if I was to talk to Art, because he works with MS Focus, and would you be willing to meet again for one of our Zoom meetings?
With the MS Focus, you mean?
Well, it's men with MS.
Sure. I mean, yeah, sure.
Would you be willing to be a speaker? Because your presence and the way you describe stuff hits all age groups and newbies versus long-termers.
I will be happy to speak. Just
okay, great. Thank you.
I can let
I'll get in touch with the right people
sure.
and get the ball rolling on it then.
Yes.
Thank you so much, Jim, for your question, for your insight, and your comments. Dr. Gyang, we do have one more question, and then I think we'll wrap it up for the evening. Someone wants to know if dysautonomia can affect MS.
Okay, good. So dysautonomia, meaning there's a dysregulation within the autoimmune, like your autoimmune, not autoimmune, autonomic system. So your autonomic system, like your heart rate, urinary stuff, things like that. Not as common, but yes, there are people with MS that have some autonomic symptoms, especially with patients that have a lot of lesions in the spinal cord. That can happen, but it's not a very prominent symptom in MS. It doesn't mean that it doesn't happen, but it can happen. It's just a matter of working with your doctor to run some diagnostic tests. Dysautonomia presents in many ways. There are different tests to help with the diagnostics. For instance, a tilt table test can be helpful. There's another test called the QSART test. So without, your doctor can specifically tease out what symptoms are going on and what's the best test that we could do to try to answer the question.
Well, that is all the time that we have for now, but if you missed any part of the conference, it will be available to watch again on our Facebook page, Multiple Sclerosis Foundation. After we close out the Zoom here, the live stream there will wrap up and you'll be able to watch it from beginning to end. If you could please follow MS Focus on Facebook, Twitter, and Instagram for more times and access information. Our next conference will be after Labor Day, so Wednesday, September 6th at 6 p.m. Eastern Time with Mr. Oscar Monkey. And they will be discussing how to make extracurricular activities MS friendly for younger people with MS. And we do want to thank all of our attendees for participating. Dr. Gyang, I know you were answering a lot of questions, but I don't know if you saw all of the thank yous that came through the Q&A. And Jim, I agree with him, co-sign that we would love to have you back sooner than later. We thank you so much for always taking the time and the extra time to answer the questions as well as sharing insight.
Yeah, I'm super excited, happy to be here, and I'll be happy to come back anytime.
Awesome.